polyneuropathy and myopathy. So there are several tests जिसमें से सर हैंड हेल्ड डायनामोमीटर हो गया ओपीडीज में पेशेंट की हैंड ग्रिप टेस्ट करने के लिए, बट पेशेंट इतने फ्रेल होते हैं कभी कभी आईसीयू में वो कोऑपरेट नहीं करते. Most easy is 6-minute walk test. In OPD, you hardly need a 30-meter corridor to do this. So there you make the patient walk for 6 minutes and see how many laps the patient covers. Ideally, it should be more than 300 meters. Less than 300 meters, यानी 10 चक्कर वो कम काट रहा है. That means the patient is at very high risk for functional disability, very low cardiovascular reserve. Okay, so there are several factors which can lead to physical impairment that can lead to muscle wastage. Most important is prolonged bed rest and inactivity. Muscle की deconditioning हो जाती है. Systemic and intramuscular inflammation at the levels of myosin filaments it works. There is loss of myosin fibers. There is loss of axons. So there is multiple things going on together which affects your muscle mass and axon. So this is the electron microscopic view of a single nerve. There we can see this the below pointer है Amit.
हाँ.
सर ये हमारी normal nerve fibers है. You can see how many axons this has, right? Now this is our axonal neuropathy जो हमारे ICU patients में होते हैं. See, you see the number of axons are decreased. Okay. Now this is a GBDMR syndrome. जिसमें axons तो उतने ही है, but you can see the myelin sheaths is decreased, right? So now how do you see it in EMG and NCS? In nerve conduction velocities, NCS इसका normal आएगा. The NCS will be normal in this because the myelin sheaths are preserved, right? In GB syndrome, myelin sheath has gone. The nerve conduction velocity will be slow, but the number of axons here are almost normal. It is normal. So if the axons are less, the combined action potentials, compound action potentials will be low, right? So this is where EMG NCS works in ruling out in differential diagnosis. As clinicians, it becomes important that we get a diagnosis why the patient is having muscular weakness. And very typical to this affects the proximal muscles. It spares ocular muscles, right? The patient will be able to grimace, but not will be able to withdraw on painful stimulus. So this is a very important thing to rule out in the ICU, a bedside clinical tool. So coming to the cognitive dysfunction, these patients develop memory impairment. In the long term, few patients develop dementia as well. If it is not taken into account, executive dysfunction, they will not be able to do the job that they were doing previously. The amount of damage is almost similar to traumatic brain injury. So this is the effect of the morbidity that we are discussing. So this is a very good tool for assessment of cognitive dysfunction in the follow-up. So you can have this thing in your OPDs as well. This requires a little online certification. It is a simple certification exam. Anybody can take up that. Simple like NIHSO. This is you just need to fill up the details. So executive function के लिए like for the toddlers we do इसको connect करो, right? Naming. What is this animal? How easily you name these animals, right? Memory. Say some random words, unrelated words, and tell the patient to repeat it, right? Forward order में numbers, backward orders में numbers. Say any random numbers and बीच में alphabets जहाँ पे A आ रहा है, tell the patient to squeeze your hand. Like it used to be in mini mental examination also. Previously we used to use MMSC. Now this is more conducive to testing in the OPD levels. Okay, and see we should all have it in our OPDs. You can just download it and print the forms. Okay, the maximum score is 30. Above 25 is worsening her lifestyle modification that is needed for these diseases. So it took her 2 years to get convinced that she needs PKI when she was completely bedridden. So this is what PTSD does.
The PTSD occurs more in the young patient.
It can be any female, sir. Any female.
And the post-COVID, many patients, who were on ventilator for a long time, survived. There are many patients had PTSD.
So sir, इसमें सर एक्चुअली ऐसा होता है कि ये किसी भी पेशेंट को हो सकता है and unfortunately this is our characteristic. Any of the females can develop any age. सर एक ये होता है, ये आई थिंक नॉट फॉर द पेशेंट इटसेल्फ, हमें भी ये डाउनलोड करके एक बार फिल कर देना चाहिए. सो दिस इज पेशेंट हेल्थ क्वेश्चनर. दिस इज फॉर रूलिंग आउट डिप्रेशन. So it is a very good thing कि do you have little interest in doing things, do you feel down, do you trouble in falling asleep, do you have little energy, are you overeating or are you not eating at all? So you just fill it up. So this is a depression questionnaire. This should be also in our OPDs. These are the one of the soft skills. When we are done fighting that, how are we dealing with the life? It is one of these questionnaires.
70% of such problems are given by patient or patient relatives.
Relatives also.
Relative कि ये तो ये करता है, कुछ सिम्टम्स है, मेरा सोता रहता है, खाने की इच्छा नहीं करता है, रोता रहता है,
सर ये मतलब काफी इम्पोर्टेंट है. We don't see this. So जो आप अभी बोल रहे हैं, पिक सेल्फ, फैमिली पे क्या बर्डन पड़ता है? केयर गिवर एंजाइटी, डिप्रेशन, PTSD, रिलेटिव्स, डिसीजन टारगेट, फाइनेंशियल. सर अब पिक्स एफ से हम पे क्या असर बुरा पड़ता है, ये आप में से कोई बता सकता है? Can you tell us? इसके वजह से डॉक्टर्स पे क्या बुरा असर पड़ता है?
डॉक्टर्स को तो इग्नोर करना पड़ता है सब सिम्टम.
सर
ये सिम्टम जितने भी आते हैं तो साइकियाट्रिस्ट कैन नॉट प्रैक्टिस साइकियाट्री अनलेस कि वो अगर इमोशनल हो जाएगा तो वो
नहीं सर, इमोशनल नहीं, तो हमारे सिस्टम पे क्या फर्क पड़ता है? These are the sets of patients who get violent. These are the sets of patients, those who create a scene. Because if you look deeper, they themselves are troubled. These are the high risk, because under high emotional stress, they end up doing things which they themselves know is wrong. So that is why this is important. Clinical psychologist in your setup. When you identify while counseling the patient is showing signs of anxiety and depression, you tell them to meet this and this person. So in Ahmedabad, we had several hospitals where we had a dedicated clinical psychologist coming and talking to the relatives in general, whether the doctors refers or not. They used to go in the patient wait area, सबसे बात करते थे. So sometimes they had a questionnaire also in their hand. Are you feeling all these symptoms? They don't used to charge because the hospital used to pay them. So this is very important thing that we should have a clinical psychologist in our setup. This significantly reduced the doctor-patient relatives altercations. This was done in SIMS, sir. So we did observation how it helped. So it significantly reduced the stress amongst the doctor and the relatives. Now ABCDEF bundle, you assess and treat the pain. Patient को pain कहाँ हो रहा है? It is very important to treat the pain. Apart from treating the main etiology, spontaneous breathing protocols, assisted breathing protocols, we should very strictly follow. Every morning we should rule out if the patient needs mechanical ventilation or not. Every morning a sedation-free hour should be given. A spontaneous breathing protocol should be followed. Light sedation, we just do not want the patient to be totally sedated, paralyzed. The patient should be responsive yet tolerating the mechanical ventilation. Delirium monitoring. There is a tool known as CAMP ICU confusion assessment method. I'll share it. Early mobility. So Kaushik, when do we mobilize the patient?
Hemodynamically stable patient.
Yeah, within 48 hours. मान लो within 48 hours patient hemodynamically stable नहीं है, then what do we do? How do we?
Passive physiotherapy, NMES.
Yes. So NMES. NMES is one of the newer tools apart from passive physiotherapy. Passive means that we are moving the limb. There is no electrical stimulation.
it is like that.
Sir,
They are moving, passively moving everything.
Yeah, so I just shared, sir. So it is very good in stroke patients. It is very good in the patients with prolonged mechanical ventilation. The microelectric current is produced, and especially for the pharyngeal muscles. So what happens? It becomes easier to extubate. Otherwise, the gag reflex remains poor. We have to tracheostomize the patient. We have to keep the RT. It has significantly reduced the morbidity, long-term morbidity of the patient, and our patients have vouched for it. I'll show you in the following slides. So avoid deep sedation. This scale should also be there in our ICU charts. Richmond agitation sedation scale. So non-benzodiazepine sedatives. Avoid midazolam as much as can. Last lecture also I discussed about a central alpha blocker, dexmedetomidine. If the patient dexmedetomidine we do not use in cardiac patients in the EF mobile failure here, because it's a central alpha blocker. It will precipitously decrease your cardiac output. But all the other patients, especially in traumatic brain injury patients, sepsis patients, this really helps. Then we have opioid fentanyl receptor. It's much better because it prevents delirium. So हमें ये यहाँ पे रखना है from 0 to -2 light sedation. We do not want this. When do we want this? When the patient is in ARDS. That is why ARDS patients are more prone to develop cognitive dysfunction, because we really need deep sedation in them. Because we need PEEP in ARDS patient, and when you are giving higher PEEP, it becomes very difficult that you give lighter sedation. So in ARDS patients, we have to use -3, -4. The rest of the patients, -1, -2 is absolutely okay. We do not want our patient to be deeply sedated. So this is confusion assessment method. These charts should be there in your ICU. You take a printout and put it in your ICU so that all the nursing staff they know. So acute change in this is to detect delirium, right? Once you detect delirium, now it becomes very important that you treat it with antipsychotics. Otherwise, if the patient remains in delirium, there are very high chances post ICU discharge the patient will go in cognitive dysfunction. Okay. So this is a machine that we have a similar machine, the neuromuscular electrical stimulation. These are NMES electrodes. This is how it works, and you can put electrodes on the several parts of the body, on the lower limbs, on the upper limbs, and in the pharyngeal areas. It's a very small investment, but it really helps in the long-term outcomes. Indian scenario. So we have a very huge opportunity to develop ICU recovery OPDs. We do not have yet dedicated ICU recovery OPDs, but that's the need of the hour. Limited structured follow-up programs. We do not have a structured follow-up programs here and there. कुछ हमें symptoms आ रहे हैं, but we are not able to correlate them. There is a high sepsis burden, and family-centered recovery is essential. PICS F को भी हमें ध्यान रखना है, उनके relatives का भी treatment करना है. Now, how do we develop ICU recovery OPDs? There should be a multidisciplinary follow-up. Not the only primary physician involved, all the accessory branches, super specialist branches as and when needed, including the nutrition expert and physiotherapist. Have you heard about this? Anybody has heard about this ICU diaries? Anybody knows about this? So what are ICU diaries, sir? Diary का in general literal meaning होता है journaling. So in ICU diaries, whether it is electronic or on paper, every day the patient's relative, the doctor, the nursing staff write down something कि आज क्या हुआ in a very layman language, right? So PTSD के जो patients होते हैं, उसको कुछ delusional memories होती है. For example, we had once a patient जिसको tracheostomy थी, because of prolonged mechanical ventilation for 6 weeks because of stroke. After decannulation, patient went home. He says कि मुझे रात में कहा आता है कि somebody is piercing my throat. Actually उसको suction की memory है. But what he believes is somebody was piercing his throat. So what happens if we keep an ICU diary in very legible manner कि the patient was suction. Patient के जितना भी sputum था हमने suction करके निकाला. Patient हमारे पास इस status में आया. The relatives also write down. And at the time of discharge, that diary, that papers are given to the relative, to the patient. अभी स्कैंडिनेवियन कंट्रीज में, यूरोपियन कंट्रीज में काफ़ी प्रमोट कर रहा है सोसाइटी ऑफ क्रिटिकल केयर मेडिसिन just to prevent PTSD in the patient. It is a very futuristic things for us because हमारे पास patient लोग ज़्यादा होता है. It becomes difficult to write down everything on paper in a layman language. So now we will discuss about the rehabilitation pathways. So this is a worksheet for a post-ICU clinic. सबसे पहले जब भी हमारे पास patient आ रहा है, we assess the vitals. We feel the patient saturation is less, the vitals are not stable. Do not go ahead. Just admit the patient. That's as simple as that. Just still the vitals are good, the patients are not fatigued, the patient is not dyspneic. You subject the patient to a 6-minute walk test. As I have already told you, what do we need for a 6-minute walk test? एक बस 30 मीटर का कॉरिडोर हमें चाहिए. And to start, कोन्स रखने चाहिए, हमें एक saturation probe चाहिए. That's all. So अगर तुम्हारा patient 6 minutes में, if our patient is able to take 10 laps within 6 minutes, it's fine. If the patient is taking more than 10 laps, it's a very good functional reserve capacity. Less than 300 meter, it suggests very poor functional reserve capacity. So that's how we categorize as mild, moderate, severe. Then MOCA test, Montreal Cognitive Assessment Test that I've already discussed, mild, moderate, severe. So now you combine it. Okay, this 6-minute walk test and MOCA test both are good, means a very good recovery. This is low and cognition is normal, pure physical. So in pure physical thing, so we'll discuss what happens. What do we do in pure physical fix? What do we do with cognitive fix? And what do we do in combined severe fix? So coming to the next thing. It's a pure physical impairment. You patient just need cardiopulmonary rehab. More often than not, this pure physical impairment is because of sarcopenia, protein optimization. You have a qualified nutrition expert in your center, just refer the patient to her, and you have a physiotherapy. You plan a resistance training program. So resistance training program under supervision, so that patient knows how much weight to lift. Okay. So in Shelby we had an entire floor that was a gym. So that was mostly a musculoskeletal hospital. So we had this entire gym for a resistance training program under the aegis of supervision of qualified occupational therapists and physiotherapists. So then we have pure cognitive impairment. You should have a neuropsychiatry reference. You have sleep optimization, cognitive behavior therapy also helps in that. Again, a counselor will definitely help in that. So combined severe fix, you need to involve multiple people and consider MRI. If you see there are signs which are focal, you see rigidity, you see gait imbalance, there are focal signs, you need to go for a MRI. So we have a case discussion. This is a 55-year-old male, severe ARDS, 14 days of mechanical ventilation, had an episode of ICU delirium. 3 months later, patient complains of memory loss, no localizing focal sign, patient complains of fatigue, patient complains of depression. Like, what do we do?
Why?
Why? Okay. We assess the severity, we involve the people. Okay. We are not alone in this, we need help. So future directions, it is a long way to go. We should have a biomarkers for neuroinflammation, IL-6, TNF-alpha, but these are not very cost effective for countries like us. So low cost PIC screening tool that I have discussed, 6-minute walk test and MOCA score remains perfect for our setting. Mobility protocols, community-based rehab programs, Swajan is one of them. Community-based rehab program. You have people where the families are involved, you have similar kinds of patients. So Swajan is one of the community-based rehab programs. AI-based prediction risk service was saying before the lecture start. AI can do some things, cannot do few things. Can do a risk prediction is good. You put in all the values while the patient is in ICU. So the AI will predict now this patient will be very high risk for developing PICS post-discharge. Keep a strict follow-up for that. We do not have yet survival registry. When we get this data from all the centers, we will actually know the epidemiology of PICS in India. Okay? So take home message, I just have this message. such life is more